right, very good morning, distinguished ladies and gentlemen on the call. I'd like to wish us a very warm welcome. As posted on the chat box, we will be commencing proceedings in earnest. Just a few more seconds to get the DG, Nigeria Center for Disease Control, to kickstart the process and the proceedings for today. And as soon as we have the DG on, we will be able to, okay, so I can confirm that the DG is on the call now. All right, so we are set and ready to go with respect to this webinar. All right, so again, very good morning to Horst Hall. I like to welcome Horst and to let us know, for those who are joining us for the first time, probably, that this is the second edition of the webinar series that we have started just some weeks ago on diphtheria outbreak in Nigeria. Today, we will be focusing on vaccination response, and a bit of the conversation will also focus or center around the laboratory response and case management for diphtheria, especially among pediatrics cases in the country. As you may recall, for those of us who were here the last episode, we had a bit of conversation around this. There are questions that were raised, and we did mention then that we will be bringing other subject matter experts who will be addressing some of those issues as we move forward. Today, I can inform let us know that we have an array of subject matter experts who will be addressing those questions and the issues we raised at the last meeting. If I bring up the DG, I'd like to just do a bit of housekeeping to let us know that if we had to ask any questions from the presentation, just as we may know, that there are boxes below the tab we have. There are different tabs for Q&A where you can put your questions. But if you have general comments, you can put it in the chat box. Please let's endeavor to use the Q&A box for the question and answer when the section starts. And if you have other specific information, you can put it in the chat box moving forward. We like to also inform us that the recordings of the last webinar is now available. And so we can check that out on YouTube. Maybe the link can also be put on the chat box later. Maybe we'll confirm that. But the recording of the first series is already on our YouTube channel. For those of us who possibly missed it, or you just want to have access to it again for ease of reference. All right. Okay, so we are ready now, and it will be my pleasure. We have about 112 participants already. Thank you for joining bright and early, distinguished senior colleagues and colleagues on the call. So it's left for us to formally declare this section open and the welcome remarks. Let me most humbly bring forward the Director General, Nigeria Center for Disease Control, Dr. Ifedayo Adetifa. The DG NCDC will be bringing forward the welcome remarks and declare this meeting open. The Director General, please.
Good morning, everybody, and thank you very much, Biodun, for doing a good job of hosting. I'd like to join the team in offering a very warm welcome to all participants. I see that we already have 118 participants. The first in the series of this webinar was very well attended with over 500 participants at some point in time, reflecting the interest in the subject. This is why we are holding a second in the series to provide an update on the state of play since the first one, and of course to discuss other aspects of the response to the diphtheria outbreak with focus on vaccination. We have carefully selected faculty at this meeting who will take us through the clinical presentation, case management, why we don't want outbreaks, what this outbreak has provided is a wealth of experience in the presentation and in the management of diphtheria that we will hear, will be properly documented for historical purposes, but we advance clinical training, of course, clinical management of diphtheria going forward. We also have faculty to discuss laboratory diagnosis and what has been done in terms of the laboratory response. As you know, the identification of every outbreak starts with diagnosis. If it's not diagnosed, then it can't be managed or there can't be any response. And we then have, of course, colleagues from NPHCDA with the mandate of vaccination, immunization in the country to also tell us about the response there. I think this will be a very interesting, very informative webinar. And I look forward to proceedings and hope that all attendees also get the full benefit from attending this as well. So welcome and thank you all very much for your time. Bye for now.
All right, thank you very much, DG. We quite understand the competing engagement and how you still make out time to represent, to give your necessary remarks. It's very heartwarming and well appreciated, sir. All right, with that, go ahead. We got from the DG. I think it's best for us to just move on to the next presentation. I'm just trying to confirm the signals. From what I have, Dr. Bassi is currently, that's our first presenter for today, who will be taking us on the vaccine-related topic. He's currently in an assignment, competing engagement. We understand the times. So Dr. Adejoke will be representing him, and he's already on the call. And to take us through the first presentation today on vaccination response to the ongoing diphtheria outbreak in Nigeria, what do we need to know? There have been a lot of questions around, do we need to go for booster doses for those of us who have been involved in the childhood vaccination schedule and all that? What do we need to do? So a lot of questions around vaccination response. I'm sure Dr. Adejoke will be able to do justice to this as we go on. So again, if we have questions, let's endeavor to put them in the Q&A box and we'll put them together and the whole will be addressed at the appropriate time. If we are set, about 156 of us now on the call, great. So let's move on as we welcome Dr. Adejoke for the first presentation. Over to you, Doc.
Thank you. Good morning, DG. Good morning, Dr. Abiodun, directors, other colleagues on the call. It's my pleasure to be here representing Dr. Bassi, the Director of Disease Control and Immunization. So we have a short presentation on what we have been doing so far. We know we have been collaborating with the NCDC throughout all aspects of this response. So this is just a basic outline for the presentation, the background, give the updates on routine immunization performance, updates on the diphtheria outbreak, the challenges we forward, and then the conclusions. So in collaboration with our partners and donors, Nigeria has been developing ways and innovative strategies to boost immunization coverage in the country. And since 2017, when the NERIC, which is the National Emergency for Routine Immunization Coordinating Center, was established to be able to boost immunization coverages across the country. And the aim was to leave no child behind. And the NCDC document outlines, we have a document which was developed at the start of NERIC, which is the NCDC document, which is the Nigerian Strategy for Immunization and Primary Healthcare System Strengthening. And this was to increase the overall focus and strategies and targets of them towards improving RI and strengthening PHC. So we know that COVID-19 negatively impacted on routine immunization and RI services because it shifted funding and other resources away from routine immunization and traditional PHC services towards pandemic response. But despite these shifts, because there was some kind of system that had already been put in place, there was still some significant improvement from 33% from the NICS mix of 2017 to 57% for immunization coverage across the world. So we still have gaps. We have some LGAs we will name as zero-dose LGAs because they've not been receiving, they've not been conducting optimally with routine immunization. And these gaps have shown with the outbreaks we've been having, CVDP, measles, meningitis, diphtheria, and so on and so forth. But we are making significant progress and efforts to be able to improve routine immunization and stem the tide of all these outbreaks. So the update on routine immunization performance, as we can see, from 2017 upwards, these are the various, the very light yellow is the NICS mix. And this is where we have, though there have been some improvements, we have not gotten to where we want to get yet. But we use the NICS mix as our standard because that's a full survey and covers the entire country. The smart surveys and all the NDHS usually just take pockets and extrapolate. So, like we earlier explained, we are experiencing low coverage up to 2016, but there has been some improvements with the establishment of the NERIC, and this led to us establishing CERICs as the state's emergency routine and also the LERICs, particularly in poor-performing LGAs. So from the the comparison between the 2016 and the 2021 NICS mix, we can see that most states made significant improvements. 33 states out of 36 plus FCT actually increased their Penta 3 coverage. Penta 3 coverage is what we use to judge immunization during surveys. So most states made progress, apart from Borno, Anambra, Ogun, and Ondo states. Those were the states that there was some decline in progress. They actually did not move further, especially with Borno State, which had a decrease in about 18% of that. So based on the reports we've been getting, the NICS mix, the NDHS, and the 2021 and 2026 NICS mix, we categorize the states based on their performance so far. And based on the improvements that we've had so far, we don't have very low, we don't have any states below 10% anymore. There are still some low states, that especially Sokoto and Zamfara, but those are things we are working towards to improve those coverage. But most states have actually improved with pockets of zero-dose areas across the LGAs and wards. So the update on diphtheria outbreak and our response plan. So I know we are familiar with this and this has been ongoing, but cumulatively, we've had quite a number of outbreaks, mostly in Kano, Yobe, Lagos, and Osun states. And hence the agency uses now with NCDC to craft a plan to be able to respond to these outbreaks with vaccination. We noticed that most of the cases were from Kano, and that it was significant that the ages that were mostly affected were between 2 and 14 years of age. And we can see that quite a number of them were unvaccinated or partially vaccinated. So for generally our response has been, we have a representative at the Diphtheria TWG with NCDC, and we have also collaborated with the NCDC to be part of the rapid response teams that have been deployed to the states where these outbreaks have occurred to be able to support response activities. So according to our vaccination policy and for outbreaks, for children less than 4 years old, it is recommended that we give pentavalent vaccine. And for those that are above 4 years and health workers, they are giving TD vaccine, that's tetanus and diphtheria. The diphtheria is a fraction of it, that is why it is in a small t. So we planned for 3 rounds of intensification in those LGAs in the states and the LGAs where this outbreak has been confirmed. And the intensification is going to occur in 3 rounds, that's in February, March, and April. We've actually conducted the first round in March. So we spread it across the LGAs that we have those that have the outbreak. And then we also included all other LGAs that have low RI coverage to also boost their immunization coverages with this round. So additionally, we have also supplied extra pentavalent vaccines, which is where the diphtheria bit of the vaccine is in the routine immunization schedule, to the 36 states and FCT to vaccinate children less than 4 years old. And we also deployed 500,000 doses of TD to Kano during this first round of intensification to cover children ages 4 to 14 years old, and also the healthcare workers who are most at risk because of their contact with this with the cases. We have made some media appearances, both alone and then also with NCDC, to be able to inform people about the intensification and what the NPHCDA is doing in response to the outbreak. And then we've also had integrated jingles, TV and radio. And what we mean by integrated is that we've mixed these messages so that apart from responding to the outbreak, we're also teaching them, or we're also informing them that they should also make sure that they complete their routine immunization, and that they also use every available opportunity when we have supplementary immunization activities to get their children vaccinated. So this is the map of how we spread the COVID-19 and RI intensification across the country. So we had the resources for COVID, and then we used that, leverage that to be able to do this intensification across the country. So we covered 150 LGAs across 18 states to make to cover the outbreak. This is just so those in red are the 0-dose LGAs that we have known traditionally that they've not been they've not been performing well with the routine immunization. And then the LGAs in purple are those with the diphtheria. And then COVID-19 LGAs were those that they have also been performing poorly with COVID-19. We can see that some of them overlap. And then we just use the opportunity to give an integrated response across the country. This is just a breakdown of those LGAs, 0-dose, the outbreak LGAs, COVID-19, those that had low, and some of them overlap, and then we just went to the 150 LGAs across the 19 states. So particularly for Kano, where we actually deployed the TD vaccine, because that's where most of the burden was. And this is just the outcome. We're able to vaccinate at least 150 people, more than 150 people with the TD vaccine between 4 and 14 years old with the TD vaccine, apart from the the penta vaccine that was deployed to vaccinate those below 4 years of age. This is just a breakdown across the LGs, how the response was done. So our challenges and the way forward. So generally, we are still experiencing a weak health system, and this is contributing generally to the inadequate service delivery and poor RI performance across some parts of the country. So especially in the rural areas, people are not willing to stay. We don't have adequate number of skilled workers for plant intervention, and then inadequate fixed or outreach sessions to be able to boost immunization coverage across the country. There's also inadequate quantity of TD in the country for the use of age group. Mostly the TD is usually for pregnant women So we took out of that stock, and then we're trying to get more into the country so we can cover the age group above those that are for routine immunization. And then suboptimal integration of services in most states and LGs. So most states and LGs are just, when they move from program to program, they're not using one opportunity to be able to boost other services across those LGs and states. And then insecurity in most parts of the country, limiting access of health workers to be able to give these interventions across the country. So our priority interventions. So for service delivery, we're going to continue our conduct of the routine Nigerian intensification in the identified poor performing LGAs, also an outbreak response in the affected LGAs or states. Then we are already procuring, the memo has gone out, and we're already in the process of getting TD vaccines to continue the response across the states for the outbreak. Then provision of adequate and skilled human resources. We advocate for provision of skilled and human resources that should be equitably distributed at subnational level. AC services, including which utilization is part of it. And then capacity building for mid-level managers and service providers. One of our aims that very soon conduct a mid-level managers training for all our PAT service across the country to be able to boost their capacity, especially in the areas of integration, so they can boost routine immunization coverages. And for data management, we continue real-time SMS reporting. We have already piloted the routine immunization on EMID. So these are electronic management of immunization data, and this was used for COVID, and so that it can give us real-time reporting as people are being vaccinated, and we can actually probe and analyze better and be able to respond faster. Conduct of quarterly LQS is lot quality assurance service. We conduct them quarterly to find out what we're doing, where our challenges are. We also conduct between quarterly TQS as data quality assurance services, also to work on our performance indicators, and then to establish zero-dose learning hubs, and then to scale up RI app for data quality improvements. For advocacy, communication, and social mobilization, we have already rolled out integrated PAC jingles, and we're already into working with the states to engage the communities for the strategy rollouts, and they were implementing the human-centered design approach, especially among health workers. Then for part of the integration, we have previously developed integrated work plans by encouraging the states to improve on that, harmonize all the work plans so that we can sustain integration across all levels, and then coordinating with the National Emergency Operations Center and other PAT programs also to be able to harmonize all our activities, and then optimize all opportunities available, whether it's SIAs, whether for polio, non-polio, to improve routine immunization services. And then we have prioritized, like we said, the zero-dose LGAs have been identified, and there's already a plan in place for zero-dose reduction, for us to intensify these strategies, and then intensify also routine immunization to be able to boost coverages. And then we're advocating for prioritization of funding support to, especially at subnational level, to implement routine immunization and other PHC activities. So in conclusion, we want to sincerely appreciate the Director General of the NCDC and the entire management. And this is an appreciation from the NPHCDA Director, CEO and his management team for the opportunity to share our experience on the vaccination response, especially with the ongoing diphtheria outbreak. We know we have been collaborating on many other activities, and that this relationship will continue to grow stronger, and we should be able to continue to use all our resources, especially those that were really firm during the COVID-19 pandemic response, to respond to the diphtheria outbreak to improve health systems. Thank you very much.
All right, thank you so very much, Dr. Joke Oladele. Thank you for standing in brilliantly well for Dr. Bassi, the director, on this discourse. I believe there are a lot of questions around immunization, which will be coming up when we have the Q&A section. I was looking forward to also see what is the policy around provision of booster dose, knowing fully well that as a country, we have a routine schedule for 6, 10 weeks and 14 weeks. And after which, if these toxic vaccines, if they wane off in the system, how well do we ensure that there is provision for booster dose, aside those who are just possibly due to 0 doses who are infected, or not vaccinated? Could there also be issues around vaccine failure, vaccine potency, and all that could be possibly driving this current outbreak? A lot of other questions will come up. So Dr. Joker, I'm sure you are on standby. Colleagues raising hands on the call. Sorry, it's not yet time to have the questions. So please bear with us. I will quickly take the next presentation. So at the end of our presentation, the second and the third, then the floor will be open for a very robust plenary section where we can all discuss further. Right. Again, thank you very much, Dr. Adejoke Oladile, for standing in brilliantly for Dr. Basio Posen, the Director of Disease Control Immunization at National Primary Healthcare Development Agency. So we move on to the next presentation, and that is taking us to what has been the diagnosis like, what are the challenges, how far have we gone? So taking us through the diphtheria outbreak laboratory response in Nigeria, the journey so far. It's my pleasure now to receive Ms. Emma Ekeng, who is the lead of the laboratory pillar of the National Diphtheria Technical Working Group. Ms. Hene is she's from the National Reference Laboratory of the Nigeria Center for Disease Control. Diphtheria lab response, the journey so far. Ms. Hene, the floor is yours, please.
Good morning, everyone. Good morning, DG. Good morning, Dr. Abiodun. Good morning, colleagues. My name is Emma Ekeng, and I work with the Nigeria Center for Disease Control National Reference Laboratory, Abuja. So I'm here to take us on the journey so far in laboratory response to diphtheria outbreak. So I'll start with a quick introduction. Diphtheria is an acute bacterial disease that affects majorly the upper respiratory tract, and is caused by Corynebacterium diphtheria and occasionally Corynebacterium ulcerans. And this is normally found in animals, but can also infect humans through direct contact and secretions. Symptoms may include fever, sore throat, malaise, a pseudomembrane, which is a thick grayish-white covering at the back of the mouth, the nose, and the tongue. And the patient may also show symptoms of swollen glands in the neck, difficulty in breathing due to blockage of airways, and heart, nerve, and kidney damage. Some characteristics of Corynebacterium diphtheria: it falls under the hazard group 2 organism, which may cause severe disease, but has effective treatments and preventive measures, and will also require full containment level 2 conditions. That's the use of safety cabinet class 2. The organism falls under the family Corynebacteriaceae and genus Corynebacterium, and has 4 biovars: gravis, mitis, bofanti, and intermedius. But the major biovars are gravis, mitis, and intermedius. Corynebacterium is a small pleomorphic bacilli. It's a gram-positive bacilli, which may be arranged in V forms, Chinese letters, in pairs, and in single cells. So Corynebacterium diphtheria, most of the species are non-hemolytic on blood agar, but some biotypes may show small zones of partial hemolysis. They all grow on blood agar, Hoyle Cellerite agar, Tainsdale medium, within the period of 18 to 24 hours at 37 degrees centigrade under aerobic conditions. They are catalase positive, oxidase negative, nitrate positive, but some like Belfanti may be nitrate negative, urase negative, and pyrazinamidase negative. So how our journey started. As at March 2020, there was no capacity to test for diphtheria in the whole of the NCDC laboratory network. So 5 laboratories were selected, and 8 laboratorians were selected from these 5 laboratories. These laboratories included the National Reference Laboratory, General Hospital Katsina, the Central Public Health Laboratory, Lagos, and LUTH and UMTH Maiduguri. So the training was focused on culture, ELEC, that is a toxin-producing test, and real-time PCR. And this was facilitated by our UK colleagues under the IHR Strengthening Project. After that, all laboratories were enrolled for the EQA under the UK NEQUAS scheme. So in that same 2020, LUF identified 2 diphtheria cases from the same family, sent the isolates to the NRL Abuja for further confirmation. At the NRL Abuja, we confirmed it positive for Corynebacterium diphtheria bivalve gravis, and then sent the isolates to our lab in UKHSA for further characterization to undergo whole genome sequencing to know the multilocus sequence type of these isolates. Due to the COVID-19 pandemic, most of the diphtheria activities were stalled. And then in October 2022, we had a virtual training for laboratorians and surveillance officers. After the virtual training, we went ahead to have a training of trainers in the UKHSA Colindale. Some scientists from the NRL were selected to undergo this training. And then we had a step-down training in January 2023 for some of our colleagues in the sites. So this slide shows the laboratories that were trained and the states. We trained a total number of 12 sites, including the NRLs, and from 10 states. So this slide shows the testing laboratories. So far, we have 12 laboratories in the diphtheria network. The laboratories highlighted in blue are those laboratories that are actively testing and reporting for diphtheria diagnosis. So this is the diphtheria national testing algorithm. We've shared this across our network. So I'll just do a quick rundown of this workflow. The preferred samples of choice are nasopharyngeal swabs, oropharyngeal swabs, and I would like to add that the wound swabs too should also be gotten from suspected cutaneous diphtheria. These swabs are to be transported in Amy's transport medium or Caribbean medium or silica gel packs at 4 degrees centigrade within 24 hours in testing laboratories. According to the algorithm, it is expected that the state labs are to do a preliminary culture test for this disease and then send the confirmed, the suspected isolates to NRL for confirmation. So the state labs are expected to culture these samples on blood agar, health cellulitis medium, and Tinsdale, and then do a gram stain to look out for gram-positive rods, mainly in Chinese letters, clusters, or in pairs. And then they expect to also perform a biochemical test to screen using catalase, PYZ, urease, nitrates, oxidase, API if available. Now, I'd like to highlight that at the state level, they are to report their final results as presumptive Corynebacterium species because you cannot confirm Corynebacterium diphtheria without doing either a MALDI-TOF, VITEC, API, or real-time PCR. And you cannot also confirm it unless you do an ELEC test to check for the toxin production. So when these suspected isolates are gotten from the states are trying to send these isolates to NRL. In NRL, we characterize and confirm these isolates or samples using MALDI-TOF, API, or real-time PCR. Go ahead to do the ELEC test, which checks for toxin production, and then conducts antimicrobial susceptibility testing for the confirmed isolates. So this is a distribution of samples we've received at the NRL from the different states. Some of the samples were isolates and some were clinical samples, that is the throat swabs and nasopharyngeal swabs. So we've received 61 isolates from Kano, 28 samples from Katsina, 9 from Enugu, with Niger, Bayelsa, Delta, FCT, Gombe, Jigawa, Kwara, Nasarawa, Ogun, and Oyo having the lowest number of samples sent to the NRL. So this is a slide showing the sample received at NRL versus laboratory confirmed by EPI week. And from this slide, we can see that week 6 had the highest number of samples received at NRL. That's we received 38 samples with 15 positives. So this is a summary of the culture tests reported by the states. I'd like to clarify again that there are 2 phases of testing. We have the preliminary test done at the state level for states that have the capacity to test for diphtheria using culture method. So when the states test for culture, they send the isolates to NRL. So far we have 4 states that that have the capacity. We have, 3 states that can test for diphtheria with 4 labs. We have from Kano, that is AKTH, Yobe, Luth, and CPHL. So far, Kano has recorded 334 samples tested as of week 8, and a total positivity rate, preliminary positive rate of 17.06%. Yobe has tested 8 with 2 preliminary positive cultures. Luth 5, all were positive, while CPHL tested 16 and all tested negative. So far, we've recorded a total number of 64 preliminary culture positive, that is 17.6% of total positivity rate at the states. This is a summary of samples tested in NRL. So far, NRL has received 136 samples, both isolates and clinical samples. And out of this 136, we've confirmed 46 samples, that is the 3.8 positivity rates from these samples tested, and 90 samples tested negative. Out of the samples, 59 were isolates and 77 clinical samples. So these are total positivity rates by states of laboratory confirmed at the NRL. From this slide, Kano had the highest total positivity rate of 83%, followed by Lagos, and then Katsina and Osun states. So this slide shows the antibiotic susceptibility pattern of the confirmed isolates. So far, we have tested 14 of these confirmed isolates for AST, and this is what we got. 92.85% of these isolates were sensitive to erythromycin, 78.57% sensitive to tetracycline. All the isolates were resistant to trimethoprim sulfamethoxazole, 92.85% were resistant to cefotaxime, benzypenicillin, and ciprofloxacin. So these are the activities we've carried out during this laboratory response. Like I mentioned earlier, we've had series of trainings, and we've also prepositioned sample transport materials across the affected sites and also across the other states for samples that will be expected to be collected for diphtheria testing. We've also engaged laboratory focal persons. Within the period of January and February, the National Rapid Response Team were deployed to states that were affected with this outbreak. And the laboratory representative from this team engaged with the laboratory focal person in the states to mentor them on sample collection, data management, and testing. We've also been able to develop some job aids for sample collection, packaging, and transport, and we've shared across the network. And then the states are trying to do a preliminary culture test at that level. We also provide remote support to the testing sites. During this rapid response, we used the opportunity to assess some labs. We've assessed 13 labs so far for the capacity to test for diphtheria. And these labs were from Kano, Lagos, Yobe, Osun, and Katsina. The state testing labs also gave weekly updates from the network laboratories to know the number of samples collected, number of samples tested, and number of positive samples. We've also given weekly updates to the National Technical Working Group to know the challenges so far, our next steps, and our ongoing activities. And NRL still tests for ELEC and PCR. And we also have plans ongoing to procure reagents and deploy them to the states. So this is a summary of laboratory assessments. That is the 13 labs we've assessed. This is just a general summary of what we got from these labs, general strengths and weaknesses. So we found out that most of the labs had the capacity to do routine microbiology tests, that is microscopic culture and sensitivity testing. And they had the basic equipment for culture, incubators, autoclave, and microscope. But they had a general weakness. Most of them lacked biosafety cabinet class 2. Most of them were not trained for diphtheria testing. Most of the staff were not vaccinated for diphtheria. And some of these labs had inadequate space to accommodate BSs if at the end of the day, BSs would be given to them. And this is a general challenge. All the labs lacked diphtheria-specific reagents to test for diphtheria. We've also faced some key challenges during this response. I'd like to add that some of these challenges have been addressed, but I'll still mention them. At the initial stage, we had insufficient sample transport materials to share across the states because initially we were using an Amy's charcoal transport medium to collect the samples, and this was quite scarce in country. So on the long run, we found that we could use Caribbean medium for sample transport. So this addressed this challenge, made the work easier. So we've shared this sample transport medium across the states. Also, the testing site in Kano, the laboratorian there also faced work overload because Kano had the highest number of samples received, and we only had one trained laboratory person in Aminu Kano Teaching Hospital. So she was actually overwhelmed with the samples coming in to add to her routine duties. But we made an advocacy visit to the hospital management and the surveillance team in the state to assist her with more staff to help her with the diphtheria testing. We also lack diphtheria-specific reagents in all the labs. At the moment, the state labs that are testing just use blood agar to test for diphtheria and the routine biochemical reagents. We also have few trained scientists on diphtheria, and few of these laboratories have functional BSs. Some have not been certified and some failed certification. Another challenge we faced was delayed turnaround time and low positivity rates. So this is the first outbreak of its kind, and we have learned so many lessons, and we are still learning too. And some of these lessons learned, we've learned the importance of lab readiness and capacity to respond to outbreak. When we had the first training in March 2020, and we didn't foresee any outbreak coming, so we just had the training, and then we had the training, another training in 2022 in October. So what if we had not built capacity to train to test for diphtheria? It would have been a disaster for the country. We also learned the importance of having laboratory reagents and resources available always. Yes, in March 2020, when the sites were trained, they were given reagents to kickstart
testing, but we had few samples coming in. So these reagents stayed and they got expired. And then in October 2020, December 2022, when this outbreak occurred, thankfully, we had some reagents that we used from the training to respond to this outbreak. And then the PCR reagents that we used in March 2020 were the reagents we used in this outbreak response. So it's a lesson for us that even when we want to procure our reagents, we should also look out for a long shelf life. Another lesson we learned was the importance of strategic partnerships and collaboration. I would like to use this opportunity to thank our UKHSA colleagues for being proactive and for foreseeing this outbreak happening, because they were the ones who pushed for us to do this capacity building in March 2020 and in October 2022. What if this was not done? It would have been a disaster. So we'd like to thank our UK colleagues for pushing this through. We also learned the need to validate new protocols beyond the norms. Yes, we were trained on culture, ELEC, and PCR, but these tests were focused on isolates and not direct samples. So thank God for our DG who pushed us to also explore other protocols that we could use to do PCR on the clinical samples to address this low positivity rates. And I'd like to use the opportunity to also encourage our laboratory colleagues in other labs, even if your lab has not been optimized for diphtheria testing, please be on the lookout for suspected Corynebacterium species. You may see them in throat swabs, you may see them in wound swabs, because I remember one of our trainings, some of our colleagues were surprised that they see this gram reactions and growth in their routine microbiological tests, but they just pass them as contaminants. So please, our laboratory colleagues, still look out for these organisms. And when you see any suspected one, please notify us at the NRL for us to give you further guidance and send them to the NRL so we will not miss any case. Finally, we also learned the importance of efficient documentation of events. Is a new outbreak. We are still learning. We are still seeing new cases beyond what
we know. So we've learned to also capture events, take pictures, and also note unique case details. So our next steps, we plan to develop a national guideline for laboratory diagnosis of diphtheria. This will be coming on shortly. And we also want to focus on whole genome sequencing for our confirmed isolates. There's a limit to what our routine culture and ELEC can do. So whole genome sequencing will be able to answer some burning questions like the circulating strain, the dynamics of the infection, the transmission, and also the sequence type available. We also intend to explore protocols, like I mentioned earlier in the previous slide, on PCR, on clinical samples, and also do some metagenomics on these confirmed isolates. And we also plan on scaling up our laboratory expansion. We want to assess more laboratories across the Federation to add to our laboratory network, and also increase the number of scientists to be trained on diphtheria diagnosis. We also plan to support the testing sites with reagents and consumables to strengthen laboratory diagnosis of diphtheria. I would like to use the opportunity to acknowledge my employer, Nigeria for Disease Control and Prevention, the management of the NCDC and the National Reference Laboratory. I also like to acknowledge our UK HSA colleagues for pushing this through for us, and not to mention our Professor Andrula and Dr. Baharat for their mentorship and for introducing us to have the capacity to test for this. Also like to acknowledge our other partners, MSF, World Health Organization, and finally, my colleagues in the NCDC Diphtheria Laboratory Network for their consistent push and their resilience in ensuring that laboratory diagnosis is strengthened across the network. Thank you, and over.
Okay, thank you very much, Emma Keng, the lab pillar for the National Diphtheria Technical Working Group. Mr. Abiodun Oguni, who is supposed to anchor this webinar, is actually having some issues with his network, so I will stand in for him while he still tries to sort it out. My name is Bola Lawal, the national lead for the Diphtheria Technical Working Group. Once more, thank you very much, Emma Ekeng, for that detailed presentation. I believe colleagues on the call actually have lots of questions to ask, but let us kindly note them down. We'll want to take all the presentation first before addressing the questions. And the last but not the least on the list of speakers will be Dr. Salma Suede. She is a consultant pediatrician and the a consultant pediatrician and the case manager for the management of diphtheria in Kano State. Without further ado, I want to actually hand over to Dr. Salma Suede for our presentation. Over to you, Dr. Salma Suede.
Good morning, Dr. Bola. Good morning, the Director General NCDC, my colleagues, ladies and gentlemen, good morning. Can you see my slide, please?
Yes, we can, but can you kindly put it on slideshow?
Okay, let me. Can you see it now?
Not yet. It's still not on slideshow yet.
Is it there now?
Not yet. Can you go to the upper left end of your screen? 1, 2, 3, 4, the fourth button from the left, upper left.
Upper left,
Upper left corner, are you there?
Yes, I'm there.
Okay, after the save, then we have the undo, redo. Then the next button is actually slideshow. You can click on it. Upper left corner of your screen.
I'm not seeing anything there.
The fourth from the left. That's after save, undo, redo, the one with the play button on it, just before the
on the
upper
So
left
she can
corner.
actually use the lower right, the last
which is the
icon.
lower actually.
Last icon on the lower right.
Last icon on the lower right. I think I have to read. I'm going to leave and come in again, please.
Dr. Salma,
Yes, sir.
please, can you email your slides?
Okay, then let me send it to you.
Yeah, all right.
Okay.
Thank you. While we wait to sort this technical issue out, for colleagues who are requesting for slides, we will, just like in the first series in the webinars, we will have a conversation with faculty, and we'll share these slides and make the recordings available shortly after this webinar. So just to let everybody know.
Alternatively, DG, sir, while we wait, is it possible to take some questions so that we buy some time, sir?
Yes, we can take some questions while we try and sort this out. I think there are already a few.
Yes, sir. Yes, sir.
Please carry on. Yeah.
All right, sir. Dr. Ladun, do you want to help us out? I don't know if Dr. Ladun is still there. I should just bring some of the questions forward.
Good morning, everyone.
Good morning, ma'am. You have the floor.
Okay, so colleagues, while we're waiting for the next presenter, we'll quickly go through some questions. And some of the questions here are addressed to the first and the second presenter. And then when we take the third presentation, we'll also take some questions as well. So the first question here says, kindly explain MICS, NICS. I believe that is for Dr. Adejoke from NPHCDA. Following that closely, we have a question on what strategic approaches would be cross-examined via cross-sectional survey or RCT to obtain endemicity of morbidity and integration evidence in immunization coverage. Over to you, Dr. Adejoke. Thank you.
Thank you so very much for these questions, and thank you, Dr. Ladu, for helping us to read them out. The NICS mix, the mix is the multiple indicator cluster survey, and then the NICS is the National Immunization Cluster Survey. So these are national surveys usually done by the National Bureau of Statistics to help us ascertain data. So it's like it's a more expanded form of the NGHS, that's the National Demographic Health Survey. and it goes into more details and has more coverage for, especially in the immunization part, for all the antigens and the rates at which people, the performance of immunization across. So we usually use that because it's more in-depth and well analyzed, also to be able to help us to judge if we're doing okay and how we can improve on our immunization services. If I got that well, I also saw some other questions. I'm trying to, Dr. Lada, I want to clarify if the Ngogo LGA is part of the questions you asked. I really didn't get the last one.
Okay, so the last question is about the strategic approach via cross-sectional survey or RCT to obtain endemicity of morbidity and integration evidence in immunization coverage.
Sorry, can I interrupt? That question should be rephrased to I suggest the person who asked that question should please ask it again in a way that makes us clear about what answer is looking for. Yeah.
Okay, so I'll go to the next one. Dr. Joke, is vaccination compulsory for everyone? And also, can a pregnant woman get vaccination? And at what stage of pregnancy is it safe to get vaccinated? And now talking about the Ngogo LGA, is part of the diphtheria hotspot in Kano. What's the plan to improve the uptake of vaccination in that area? Thank you, and over.
Thank you once again. And thank you, Gigi, also for helping us so that we can get better clarification on the questions. So we recommend vaccination for all children. That's routine immunization for all children less than 2 years of age. And this includes polio, the Penta vaccine, which has 5 vaccines in them, which is the influenza, Haemophilus influenza B, the diphtheria, tetanus, pertussis, and the hepatitis B. We also recommend the hepatitis B as the first primary series at birth. And then all the other vaccines, pneumococcal conjugate vaccine, meningitis A vaccine, measles, yellow fever, and the rotavirus, which was just recently introduced. So we recommend that all children complete their series of vaccinations before the age of 2. And we are still trying to improve our primary series. So, but we also always usually provide opportunities for older persons, children and older persons to get vaccinated. Like when we have our yellow fever campaigns across the country, usually it's for people between 9 months of age and 44 years. When we have the meningitis vaccines, usually for, especially when during outbreaks, for persons up to 29 years of age. And when we have measles for children less than 5 years of age. So it varies across the scope of what we want to cover to be able to reduce burden of diseases across the country. But yes, vaccination is recommended. And usually we also recommend that women, when they are pregnant, also take the tetanus vaccine. And it comes in the form of TD, which is the tetanus and the fraction of diphtheria. And that is part of what we are using also in part of the response during this outbreak, especially in Kano. For Ngogo LGA, it's the same as how we are treating all our LGAs that have 0 dose and also in outbreak. We encourage the states to be able to come up, we provide a general plan, but we also encourage them to come up with state-specific plan, knowing their challenges across their areas. So already we already told those states and the LGAs to come up with their 0 dose plan on how they want to reach previously and how to reach areas for those who are not getting immunized. And then, so we're using that, we're building on that, and then looking for the funding to be able to get to all those areas that, and all those children that are not being immunized. So the plan is to advocate, because there's and educate mostly, and then provide those vaccines and provide the resources for them to be able to get to those children and to the also older children who have not been previously vaccinated. Thank you.
Thank you very much, Dr. Joke, for that brief explanation. We still have a series of questions for you.
Sorry, Director Ma. If you don't mind, since we just took that as a break to depending when the presenter will be ready, I'm told that the presenter is ready now. Do you mind, Ma, if we could just go ahead with the last presentation so that we can have time to put all the questions together, with your permission?
Okay, that's fine. So she can actually take a break. Thank you, and over.
All right. Thank you very much. So thank you very much, Dr. Joke, for your answers. Please stand by. Like I said earlier on, you're definitely going to have more questions coming. So we thank you, Dr. Bola, for standing in when I went off. That's Nigeria's situation with network. So we quickly move on to the last presentation. Dr. Salma, we're ready for you now. Management of diphtheria cases in Nigeria, the Kano experience. You have the floor, ma'am.
Dr. Salma, please go ahead. You have the floor. Dr. Salma, if you can hear me, kindly unmute your mic.
Hello, I said next slide. Hello. Are you hearing me, Dr. Bola?
Yes, I can.
So I said, next slide. I've already finished the introduction, management of diphtheria cases in Nigeria. Hello? Hello?
Dr. Salma, I have the very first slide, management of diphtheria cases in Nigeria, the Kano experience, the introductory slide.
Yes, I said the next slide. Okay, yes. So by form of introduction, we all know that diphtheria is an acute infectious disease caused by Corynebacterium diphtheria, and it's a serious bacterial infection that usually affects the mucous membrane, heart, nerves, and hematological system. It usually affects young children, but adults can also be affected. Next slide. Hello?
Yes, you have the next slide, Dr. Salma.
It's not changing from my side. I think I will just use my own slide here, from here. Then
Okay.
you'll be changing from there, yes. You're hearing me now?
Yes, we can.
So based on the case definition by NCDC, we all know what a suspected case is. It's when a person has an illness, signs and symptomatology of upper respiratory tract infection with which is either a pharyngitis, nasopharyngitis, and the presence of an adherent pseudomembrane, or any person in whom the clinician makes a suspect diphtheria. While a confirmed case is a person with where Corynebacterium species isolated by either culture or positive for toxin production, regardless of symptoms. So the Kano State outbreak, I'm going to look at it under the following topics. We'll look at the brief statistics, the general management of complication, nutrition, chemoprophylaxis and vaccination, discharge, follow-up challenges, and some recommendations. So as of the 1st of this month, we had a total of 764 cases. Culture positive cases were 66, while those that were laboratory confirmed, we had 11 cases. Though we have some epidemiological linked cases which we are still identifying, but as of that time, it's 0 epidemiological linked cases. Now, this is like the dashboard that is being shared by CITRIP on a daily basis, and the total number of DATs that were used as of that time is about 1,054 doses of DATs were used. So this is the contact listed. We had about, as of that time, 1,341 contacts were listed. And they are currently on follow-up are 425 contacts. 916 have completed their follow-up. There were no confirmed positive cases among the follow-up contact that were follow-up at that time of reporting this as of first of this month. So this is a pie chart showing the vaccination status. More than 54% of the cases were found to be not fully vaccinated. 20% are found to be partially vaccinated. So you can see we have serious issues with the vaccination process in the state. As at 2nd of March, we have the total of 783 admission, out of which 360, making 45.9, were females, and 423, making 54%, were males. We recorded 61 deaths with a case fatality ratio of 12.2%. Average hospital stay is 4 days. 83% of these deaths occur in patients with onset of symptoms greater than 3 days. So the earlier the patient develops symptoms and come to the hospital within the first 72 hours, the better the outcome in terms of survival. And we have an average recent now of 15 admissions per day. So this is showing the outcome of management. More than 70% of our patients were discharged as at 2nd of March. We had about 12 patients that absconded, and 12.2% represent those that died during the course of management. So under management, I'm going to look at the triaging, resuscitation, how we go about doing it, the definitive supportive management we give, and how to go about management of complication. So in the triage, we dedicated a space for triaging, which is adequately staffed and equipped with all the necessary equipment for resuscitation. We have crowd control personnel that are stationed. Suspected cases are identified and categorized according to their severity. Throat swabs are taken, even cutaneous swabs are taken during the triaging, and all health workers should be in PPEs, and they should adhere to safety protocols that are put in place to make sure that contamination and transmission of disease is prevented. So during resuscitation, we institute ABCD of resuscitation immediately. SBO2 monitoring and random blood sugar critical sampling is done for all patients. We take full blood count, EUCR for all patients are taken. The need for assessment by ENT is done as soon as possible, and those patients that are identified that may need ENT intervention are done immediately, so to avert serious complication. Hydrogen peroxide gargling is instituted immediately in patients that can gargle. Nasogastric tube insertion is done by the ENT, if possible, at a very early stage, especially for patients with severe acute malnutrition. Brief history is taken after stabilization. Now, this is the DAT administration, and that administration is the key component of treatment of diphtheria. Administration is done as early as possible, and it should be, because the more you delay the administration of that, the more toxin production and the more chances of having disastrous complication. And it should be admitted. We admit that once So that means if you just make the calculation of the amount of that should be given to a patient, we make sure that we give that amount as a first-time dose. And we all know that is of equine origin. There is high risk of rare but severe anaphylaxis reaction, but though frequent reactions are not out of do happen. We know that there are two types of reaction that can occur. We can have the pyrogenic reactions to that, and then we can have the severe anaphylaxis reaction. Therefore, we take several measures to taken to mitigate this kind of reactions from happening. The first one is that you should all know that is given only in the hospital setting. And before mixing it, that is the second risk. We have to make sure that it is warm to room temperature. And this Beresca test is done to identify those patients that are allergic to that. And if they are seen to be allergic, if it's the mild reaction, we can go ahead and give them a pre-medication. But if it's one that after you have repeat the second reaction, the second test, and there's another severe reaction, then you should not go ahead and give that. So before starting, we should make sure that the patient has had at least one functioning IV line instituted. 0.1 ml of that is injected on the forearm, and you wait for 15 minutes to look for a reaction in form of either a wheal, redness, or itching. If it's just a wheal that happens, then we can increase the dose for the test to 0.25 mils. But if the wheal continues but there is no other itching and redness, you can go ahead and give a pre-medication in the form of either hydrocortisone or epinephrine, and then you go ahead and you give that infusion. Fortunately, none of our patients had an adverse effect following that administration. The amount of antitoxin required depends on the site and size of the pseudomembrane and the duration of illness and the overall clinical condition of the patient. It does not depend on the weight and age of the patient, as the dose is aimed solely for the neutralization of the circulating toxin. Larger amounts are recommended for brain. Usually shows that the bigger the size of the membrane, the higher the production of toxins, which will also increase the delay administration. The entire dose should be administered, as I said, once, slowly over 2 to 4 hours. We start at a very low rate for the first 20 minutes, then we increase progressively to the final rate if no allergic reactions are observed. Now, this is the dose in unit of that we give in accordance to the severity of diphtheric disease that the patient presented. If it's just in the form of laryngeal and pharyngeal involvement and the duration of onset of symptoms is less than 48 hours, we give 20,000 to 40,000 international units intravenously. We dilute that in 250 mils of normal saline. We give over 4 to 5 hours, over 2 to 4 hours. For rhinopharyngeal involvement, we give a much higher dose of 40,000 to 60,000 national units. For the severe form, we give with those that come with bull neck and in respiratory distress with other symptomatology of high severity, we give 80,000 to 120,000 international units. And since the onset or since the outbreak, I think we only give 100,000 to only one patient. Most of the time, we are giving 20,000 to 40,000 international units of that. Antibiotics use. Initially, at the beginning of the outbreak, we were using IM benzathine penicillin and oral erythromycin. But following the identification of resistant strands to PCN, we changed our regimen to IV ceftriaxone and erythromycin or azithromycin. So ideally, in the protocols of care management of that of diphtheria, we are supposed to use injectable erythromycin, which is not available at the dose of 40 milligram per kg per day, with a maximum of 2 grams per day. And Every 6 hours, you give 10 milligram per kg, maximum of 500 milligram per dose. We treat for a total of 14 days. IV ceftriaxone is given at a dose of 80 to 100 milligram per kg in patients that are critically ill. What we usually use is oral azithromycin or oral erythromycin at the same dosage of that of the IV. We do not give to the less than 2 months old child microlight. Fortunately, we've not had any infant less than 6 months since the onset of the outbreak with diphtheria. All patients are tested for malaria and they are treated accordingly. We monitor the blood glucose closely with close monitoring for adverse effects of that throughout the hospital, the patient's stay in the hospital. Steroids are also part of the adjunct given in the treatment of some of the cases with diphtheria. It is given in cases where there is stridor, respiratory distress, and bull neck. It helps to ameliorate the need for tracheostomy if instituted early. We give a high dose of dexamethasone at 0.6 milligram per kg, known as the attack dose. Then 0.4 milligram per kg is given in 4 doses every 6 hours, with a maximum of 10 milligram per dose. The dexamethasone, we all know it tends to deliver rapidly to the tissue and has a very low risk of side effects. We also use hydrogen peroxide, and this is used in those patients that present with extensive pseudomembrane. The hydrogen peroxide gargle is done for patients that are above 5 years of age and is done 6 hourly. It has been shown to have immense benefit and also helps to ameliorate symptoms of acute respiratory distress and also reduce the need for tracheostomy if you institute hydrogen peroxide gargling early. The concentration we use is 6% of hydrogen peroxide in 1:6 dilution. Now, this is a child that is a 5-year-old child that came in with feeding difficulty, severe respiratory distress, and oxygen saturation of 85 to 87 in room air. He was noticed not to be improving even after we put oxygen with signs, because it shows that he has obstruction. So we employed hydrogen peroxide gargle, and after the second hydrogen peroxide gargling, it coughed out the pseudomembrane. As you can see, the pseudomembrane the tissue of the pseudomembrane that was coughed out, and immediately his condition improved. His room oxygen saturation rose to about 92% to 96% on room air, and he could be able to keep on liquid diet. So you can see that it is very, very good. It's very good thing to do to children when they come with severe extensive pseudomembrane, to have the hydrogen peroxide gargling if they can gargle. Now, cutaneous is a very rare presentation of diphtheria. We had 4 cases of cutaneous diphtheria. All the cases in our own case in this outbreak presented with throat pseudomembrane and cutaneous manifestation. So we end up querying whether we are having a toxin producing corynebacterium causing a cutaneous manifestation, or a mixed infection of both the non-toxin corynebacterium with another toxin bacterium that is causing the presentation. None had a pre-existing skin lesion preceding the onset of the cutaneous pseudomembrane. The first one is a 17-year-old girl who presented with sore throat, fever, and cough for 4 days. She resides in Ungogo local government. She had 2 siblings with suspected diphtheria. One of the sibling throat swab was confirmatory. Examination reveals a throat pseudomembrane. She was placed on that and antibiotics as per protocol. Throat swab was taken. 3 days into the admission, she complained of vulval swelling and dysuria. Genitourinary examination reveals an edematous vulva with an adhering grayish white membrane. However, all her serology screening were all negative. Vaginal swabs were for diphtheria was also negative. However, histocytology report done at Zaria was highly suggestive of diphtheria. So this is her picture. If you see picture A, that was day 1 of the time that she complained about the vulval swelling, and when we examined, we could see the grayish white pseudomembrane. That was, she's already 3 days on admission at that time. And on day 4, that's the picture B, you can actually see that there is an increase in the vulval swelling, and the pseudomembrane tends to have now is now foul smelling, and she's unable to sit. So we added IV metronidazole at a dose of 7.5 milligram per kg 8 hourly, and we employ her to sit back with diluted hydrogen peroxide at 1:10 ratio, which was done twice a day. So on day 8, that's the 11th day of admission, you could see the significant improvement. All the swelling of the vulva have subsided, it's no more edematous, and she has virtually cleared most of the pseudomembrane. She was discharged after spending 12 days on admission. Sit back with diluted hydrogen peroxide was an improvisation. We've never seen where it is done, but it worked, and so it's something that we think we should do in another patient. Then we have the second case with cutaneous diphtheria was a case of an infant who also presented with throat and vaginal pseudomembrane. She spent 6 days on admission and died from sudden cardiac arrest. She was partially immunized. You can see the vaginal pseudomembrane in this 18-month-old child. She responded very well to our protocols of management. We didn't do SIDBAT on this patient, but she was one of those patients that died within 2 hours of onset of sinus bradycardia. We lost the child. Then we have an 8-year-old boy who presented with history of cough, fever, inability to swallow, rashes, bleeding from the mouth and nose with abnormal breathing, and reduced urinary output for 1 week. He is 0 immunized. He has lost 3 siblings 2 weeks prior to presentation. On examination, he was found to be in severe respiratory distress with generalized erythematous bullous skin lesions and areas of desquamation. He had a bull neck, halitosis, and was bleeding from the nose and mouth. He was severely pale and in shock. A diagnosis of hemorrhagic diphtheria with cutaneous manifestation in shock was made. He died, unfortunately, within 1 hour of admission before even throat samples were able to be taken, or that was given. So you can see his picture. You can see in picture A, you can appreciate the generalized bullous eruption that this boy has. He has also a bull neck. You can see the bull neck there, and on picture B, you can see desquamating erythematous skin lesions. Some of them are peeling and bleeding that he presented with. So the nutrition this is a very important component of management of children with diphtheria. At admission, each patient has his nutritional status and needs are being assessed, and patients are classified as a critical patient, intermediate, or stable, based on their satiety in terms of appetite. Those that are critical patients are those patients that are unable to feed, while the intermediate patients are those that have some form of appetite, while the stable ones are the ones that can be able to eat normally. So high density energy as a form of RUTF is given, or therapeutic milk is given to the patient. NG tube insertion is done as I've already mentioned by ENT after specialist assessment. We place them on IV fluid maintenance to ensure that they have at least adequate hydration and glycemia for those that we cannot pass the NG tube as we await the ENT for assessment. TPN is the preferred, that is total parenteral nutrition, is the preferred option in the critically ill patient, but it's not available. So for stable and intermediate patients, they are placed on high density energy foods as well. Now, management of complication. We identify 4 major complications. We have sinus bradycardia, thrombocytopenia, renal failure, acute respiratory distress, and neurological complications. For sinus bradycardia, we had 35 cases, making up 57.3% of the total death of them amongst the 61 deaths that was recorded as at 2nd of March 2023. Out of which 14 cases presented with sinus bradycardia, while 21 presented with 14 cases presented with only sinus bradycardia, while 21 cases present with sinus bradycardia, thrombocytopenia, and renal failure. We identify this 3 triad as one of a dangerous triad. Once a patient comes in with thrombocytopenia, then you know that you end up developing sinus bradycardia, and it's just a matter of time they all develop renal failure, unfortunately. The standard treatment for sinus bradycardia is pacemaker insertion. Patients with sinus bradycardia and circulatory collapse are placed on oxygen therapy, anti-shock treatment using saline, atropine, plus or minus dopamine, depending on the presentation of the patient. Cases of isolated sinus bradycardia in an otherwise stable patient, we just monitor and give high dose of diphtheria antitoxin. Thrombocytopenia. We had 15 patients who presented with thrombocytopenia and active bleeding. All the patients with thrombocytopenia rapidly deteriorate within 24 hours due to lack of availability of plasma or platelet concentrate. All the patients with thrombocytopenia died, making about 40% of the total mortality. We had 11 patients that had platelet concentration of less than 40,000. Renal failure. We had 25 cases of AKI, 11 cases died, out of which, out of the deaths, 4 undergo dialysis, 2 undergo hemodialysis, ages 10 and 13, while 2 undergoes hemodialysis. One was a 2-year-old and the other one was, I think was a 4-year-old child. All the 14 cases were managed conservatively and were discharged. All the patients that died, as I've already mentioned, that had this triad of thrombocytopenia, bradycardia, and renal failure. High dose of that in patients with mildly impaired renal status and without any co-founder was found to give a better outcome in terms of the management. Conservative management involves kidney challenge. We monitor electrolytes and urine output. Interestingly, we had 2 cases of nephrotic syndrome. All were seen and managed for, one spent 2 weeks on admission, the other one 10 days on admission. They presented within 3 to 4 weeks after discharge with anasaka, with no urinary symptoms, and urinalysis revealed proteinuric level for nephrotic syndrome. They were readmitted and were placed on and managed according to protocols for nephrotic syndrome management and discharged, and now presently they are on follow-up. So we don't know whether these cases of nephrotic syndrome is as a result of delayed serum sickness, serum sickness effects following that, as some of them can come with glomerulonephritis, or as a result of diphtheric complication. Now, neurological complication. This is a medical dilemma for us. We are confused whether it's a form of a reinfection or serum sickness or diphtheria complication. We had 11 cases of neurological complication. All cases presented with progressive weakness, bulbar palsy, changes in voice, inability to swallow fluids, ptosis. We had one case that have associated paresthesias. All the cases were readmitted after being managed and discharged with an average of 4 to 6 weeks post-discharge that they come with those symptoms. Age ranges from 2.5 years, 2.5 years to 22 years. Now, Dr. Bola, if you can go ahead and play this little video of this 5-year-old.
Sorry, Dr.
Hello?
Salma, unfortunately, I don't think, okay, let me try it. Okay, fine, it's good.
So it's playing now?
Yes,
Hello?
it is.
So this is a 5-year-old girl that presented 4 weeks after being discharged with significant lower limb weakness. She's unable to be supported and is unable to walk, with associated selective odynophagia. And at the same time, her junior sister also have similar, though she's an infant, similar complication as well. Most of these patients were lost to follow up, and they were not lucky to come back and to complete their vaccination. So this is the patient that we have. 7 cases of those patients that presented with neurological complications, again presented with fever and pseudomembrane. All the cases were lost to follow up and do not receive TD boosters or pentavalent as age appropriate. 7 cases did not receive the data during the active infection, out of which 3 cases came back within 6 weeks with neurological complication and also pseudomembrane. The good news is that the prognosis for neurological complication we noticed is good. They were all placed on neurodegenerative drugs. In the case of the very young, we placed them on DHA-rich supplements, or in the older ones, we placed them on either encefabol or NATB, and antioxidants, which are all neuroregenerative and at the same time antioxidants. We give them steroids and physiotherapy, and we give them vaccination, age-appropriate vaccination and booster doses as well, right, are given. We had 15 cases who presented with, which is making 1.9% of cases presented with bull neck, out of which 9 developed acute respiratory distress and died. 2 underwent tracheostomy, but since the beginning of the hydrogen peroxide gargle, we have noticed a significant reduction in the need for tracheostomy. All the 9 patients have associated severe thrombocytopenia with extensive pharyngotonsillar membrane. So this is a case of a 30-year-old housewife who presented with 2 other family members that have pseudomembrane. She was the first that started having symptoms of upper respiratory tract infection. Then, having heard that there is a disease, there is an ongoing outbreak, when she checked and she saw a pseudomembrane, she went to a traditional barber who now incised the pseudomembrane, and it led to a fistula, a nasopharyngeal fistula, as you can see. So she presented with the remnant pseudomembrane and odynophagia, nasal speech, and regurgitation of fits from the nose. She was admitted and treated as per protocols, and then discharged to follow up with the ENT for reconstructive surgery. So for chemoprophylaxis for contacts, all contacts are identified and management are instituted immediately to avoid the development of the disease and to halt community transmission. So oral microlides are given in accordance with age for 7 days. We give vaccination using Penta to children under 6 years and a booster dose of TD to those above 6 years. All health workers at the DTU were given TB vaccine. Any close contact with sore throat or pharyngitis is considered a probable case and given diphtheria antitoxin. So what we do for them at discharge is most patients on average, we notice spend an average of about 4 to 6 days on admission, with critical cases spending 10 to 12 days on admission. Stable patients that spend less than 14 days on admission and they are advised to self-isolate. If it's a child, we told that we discuss with the parent on the need for the child not to go in order to complete 14 days on treatment, even while he's at home. Ideally, before patients are discharged, we should have 2 negative throat swabs at least 2 days apart. But it's not possible due to lack of space. We are always having patients coming in. So once we see a patient is stable, we discharge, and other logistics in terms of sample collection and the results reporting time as well. For follow-up, we employ weekly follow-up up to 6 weeks. During follow-up visits, neurological and cardiovascular assessment are carried out. We take history of weakness, changes in voice, double vision, difficulty in swallowing, palpitation, easy fatigability are all asked for each patient. And thorough examination is done. We refer to relevant specialists as the need arises. In the case of abscondment, we have some cases of abscondment. I think we had 13 cases of abscondment as of when I'm writing this report. And what we do is we notify the DSNO immediately, who now relate the necessary information concerning the patient to relevant local government DSNO. Now, the local government DSNO will liaise with community leader or ward head to make sure that the patient is being brought back to the facility. Now, we have some challenges. So that challenges that we had is, number one, we had challenges of a lack of availability of that during the early stage of the outbreak, and also around week 5 to week 6 into the outbreak, that was not available. We noticed, and that affects some of the patients that came down with neurological complication. And another challenge is the lack of expertise for pacemaker insertion, leading to us losing a lot of patients to sinus bradycardia and other cardiac abnormalities. We have also lack of injectable erythromycin, which is one of the most important antibiotics that you're supposed to give to children, especially those patients, especially those that cannot even swallow. So we don't have injectable erythromycin anywhere in the country. We don't have a functioning intensive care unit that is domiciled around the area where the DTU is operated. There is also inability for us to secure fresh frozen plasma or platelets concentrate for thrombocytopenic patients. And we have a lot of negative throat swab results, which I know that the other discussants have discussed the reason why we are having a lot of negative throat swab results. So our recommendation is we need to have an active surveillance, to have a stretching active surveillance to ensure early detection of diseases of public health importance so as to mitigate their propagation at a very early stage. We need hands-on skill training of doctors at the DTU by cardiologists with expertise in pacemaker insertion. There is need for bedside ECG monitoring, which will enable early detection of cardiac abnormalities. The need for provision of IV erythromycin and setting up of ICU, which should be manned by intensive nurses and doctors, to make available all the necessary equipment needed for fresh frozen plasma and platelets supply and storage. Then the debatable one is the need for us to look at prioritization with regards to that administration in terms of shortage. And at this juncture, I want to send an acknowledgement of to Federal Ministry of Health, Kano State, to NCDC, to Medicine Sans Frontier, and to my CMD for all the necessary support they give towards the management of and the management and the processes that are being involved in the setting up of the DTU, and also its ongoing management as well. Thank you very much for listening.
Thank you very much, Dr. Salma Hali Swat, consultant pediatrician and case manager at the Kano State Diphtheria Technical Working Group. This has been a very rich and detailed presentation, and it's interesting to have a lot of understanding from the presentation. I'm sure there will be a lot of questions. It's particularly interesting for me to see involvement of histocytology in our testing algorithm. Another common clinical features and presentations we have also seen from your presentation. The challenges, I believe there are things that are also up for discussion, either at this level or even outside this room. All right, thank you very much. So distinguished colleagues, senior colleagues and colleagues on the call, I think the floor will now be open. So like DG has also mentioned on the chat box, please, if you have placed your questions in the general chat, it will be difficult to track. So if you don't mind, please let's put them in the Q&A box. That's where they're meant for, so that it's a lot easier to track them and provide answers to them. So Dr. Yelado Kuromade is the head surveillance and IP department of NCDC. It will be good now, ma'am, to please take over from here to help us coordinate the general panel discussion on the Q&A section. Dr. Yelado, over to you.
Can I just interrupt, if it's possible? Or maybe
absolutely.
Sorry. Ladies and gentlemen, we've had a really rich presentation, and I think before we put the presenters in the firing squad or firing range, can we just appreciate them by a round of applause? If you can unmute wherever you are, or use the appropriate emoji. I think they have done an excellent job in covering all of the topics for this faculty. So, I mean, for this webinar. So either you show a video of yourself clapping or anyhow, but I just appreciate the faculty any way that you can for the really excellent talks they have given. And can I just say, before we close, Dr. Salma and the team in Kano, yes, Kano has had to deal with the burden of looking after most of the cases in the country and the stress, managing the morbidity and the suffering of patients, and even seeing some of the patients die. And this is the downside of what has happened. On the upside, there's been now significant local experience of a wide range of manifestations of diphtheria that probably were not covered adequately, even in some of the textbooks that we were all trained with, or a wide range of clinical experience that can provide an update to what has been written down. And it is important. This is often the difficult part. It is important to document every bit of that experience, every peculiar case, so that they can be shared, published, and shared widely beyond even the limited, and I'm careful saying limited, there are 278 people here, but you want to document this beyond, for access beyond these 278 people, and of course, for providence, so that this is a constant reference material. So thank you very much to you, AKTH colleagues, Dr. Hassan Anga, MSF, MMSH management, the State Ministry of Health, and every WHO and everybody who has been part of this, of course, along with the NCDC team as well. But kudos to Kano colleagues. They've really done exceedingly well in this outbreak. So back to you, Dr. Ladu, unless you want me to do Q&A for you.
Thank you so much. Actually,
Okay, thank you so much, DG. Once again, we'd like to say thank you to all our speakers. You've done a fantastic job, excellent presentations, and thanks for all the efforts that go into preparing for this. There's been an ongoing live answering of the questions on the Q&A chatbot. All the immunization questions have actually been attended to. Please take time to go through that, and we'll only take some of the questions for Dr. Sama based on our presentation, and maybe one or two for other presenters as well. For Dr. Sama, there is a question here on that. Can a suspected case be given that? Isn't hydrogen peroxide to do some tissue damage to surrounding health tissue? And also, there's actually another question on how the cases on admission in Kano being confirmed. I think DG has attended to that. That we have a case definition. It's either it's clinically compatible or we have a laboratory confirmed case. So I would go to another question on how many of these absconded patients were located via the current existing channel, either through the LGA, SNO, or community informants. Over to you, Dr. Sama.
Thank you very much for the questions. Now, hydrogen peroxide we use the 6% hydrogen peroxide in 1:6 dilution. And because we want to avert complications, we don't do it for less than 5-year-old, because we all know that hydrogen peroxide can cause gas embolism and also causes excoriation of the throat membrane. So in that concentration, we know that most of them don't have the issue of corrosive effect of hydrogen peroxide. For the confirmed cases, I think we in terms of clinically suspected, because I think it's a part of the case definition. In any case that even the clinician have a high index of suspicion of diphtheria, then he can go ahead and think of doing, go ahead and treat the child in accordance with the protocols. Because I think there is need for epi-linking of cases. Most of there is clustering. If you see one positive or two positive cases within a community, the other cases that will come, there is high chance of them also being diphtheria if they fall under the case definition of diphtheria. And the issue of antibiotic use at the community level has affected the outcome of having positive results, even after you take the throat swabs for testing. Now, for the absconded patient, almost all of them were brought back to the facility and they completed their treatment and were discharged. And were discharged and are presently on follow-up, though some of them we've lost to follow-up, but they were brought back to the facility. Thank you very much.
Thank you very much, Dr. Sama, for that response. I believe Dr. Bola is still on the call. Dr. Bola, the question here is addressed to you as the IM diphtheria. On injectable erythromycin, what's the plan, if any, of NCDC procuring and storing for situations like this in the country?
Please let me answer that question, Dr. Ladu. I recognize the NCDC is a quote-unquote trusted brand government agency that people look upon with some, at least with positive disposition. But I think it's important that we all need to remember in the various centers that we work in, that we have a primary responsibility to advocate for everything that you need for the care of patients that you see on a day-to-day basis rather than these outbreak situations. There certainly is a bigger need for intravenous erythromycin than waiting for a diphtheria outbreak. For all of the atypical pneumonias, all of the other special infections that need to be managed in children and others, we should, all the consultant pediatricians, all the pharmacists, all those who are responsible for what kinds of drugs need to be stocked in hospital, should advocate to have all the preparations of medication that children need, especially children who can't swallow tablets or the like, available. That's the thing. If that was already in place, then we will not be waiting to look for IV erythromycin in the context of an outbreak, because this is part of why we say, a functioning resilient health system is the primary factor or the primary foundation on which everything else related to health security will build on. Okay, you can't, in the context of an outbreak, now begin to look for IV erythromycin. It's going to be more expensive, you may not find, whereas it will have been better, recognizing that there's a need for it, to have it as part of drugs that are available, create a demand so that suppliers can provide, not that we now start looking for, international procurement or continental procurement to find this medication now that it's needed in the context of an outbreak. I'm sure there's a bigger need for IV erythromycin than the 500 or 1,000 plus patients that we have seen in the context of this outbreak. But having said that, we will also explore, again, stockpiling is different. You stockpile what you need as part of preparedness should something happen. And usually you can only keep a small stock, hopefully with a long expiry date, in anticipation that something may happen, not for routine care or sort of routine outpatient or inpatient consultations, as the case may be. Thank you. Back to you.
Okay, thank you, DG, for that explanation. And we'll go back to Dr. Samuel. There is also a question for the risk communication person here, and I'll give that to Dr. Diso quickly and briefly. Dr. Diso, there is a question here that says, what are the messages that borders around misinformation and disinformation on diphtheria in Nigeria, and what is the risk communication is doing around that? Thank you, and over. You have the floor.
Okay, good afternoon, DJ, and good afternoon, everybody. With regards to misinformation, we have actually deployed a mechanism for listening, community listening, and then getting feedback from the community. We've not really gotten any significant misinformation on diphtheria, except what we picked on our radar, what happened in Kano, where people are attributing it to witchcraft. So we've used the local mechanisms, infrastructures to correct this misconception. Luckily, Kano State is one of the 12 states where we have built their capacity on infodemic management at the sub-national level. So they can also listen and using both offline and then online tools. Meanwhile, what is more important is to prevent misinformation by bringing out high quality information in a timely manner. And then, so we know that diphtheria is because of failure of vaccine uptake or vaccine utilization or even vaccine coverage. And then, so we've been trying to emphasize that in our messaging. And then messaging both on our platforms and as well as working with the state health promotion officers to ensure that they disseminate this information and other preventive measures to be able to make sure that they detect early and then respond promptly to stop the transmission of this. So essentially, that's what we have for now. We continue to listen. And in the last 1 month now, we've not been able to pick any thing concerning misinformation apart from what we have picked from Kano. Thank you very much.
Thank you very much, Dr. Diso, as the head of our risk communication, and has provided information around that. So, Dr. Sama, lastly, we have questions on vaginal cutaneous manifestation of diphtheria infection. The question is, what is the likely source of vaginal cutaneous manifestation? And do you have cases of females aged 18 and above with vaginal diphtheria? If not, are the women that age group at risk of vaginal diphtheria? Thank you, and over.
Thank you very much. Well, there are some reports of vaginal diphtheria where before, but the thing is that most of the time they say that there has to be, in the case of the infant, you can say that if there is diarrheal disease and then there is dermatitis following diarrhea, the nappy dermatitis, it may serve as a NIDS for the development of cutaneous diphtheria. Or in her own case, if she has candidiasis and then she itches and there's some of like an auto transfer from her throat maybe, or she touches anywhere that is contaminated with diphtheria and she scratches, and then she can now vaginal diphtheria. So we are a bit conflicted whether it is just solely an auto kind of inoculation, or it is two strands, one of non-toxigenic, as we know, happening in a pre-existing lesion if she has a scratch from candidiasis, or it's another corynebacteria that can cause both throat pseudomembrane and vaginal manifestation as well. And she's the only one that we have so far. She's the only 17-year-old. So, and this is not a common thing. I think the ages we had an infant and we had a teenager. So I can't say anything. Watch and see. We've not have any since the two of them, one died and one was discharged. But we'll be on the watch out to see if we see more and we see the ages being almost the same. Then there is need for us to do further investigation to find out if there is any thing that is predisposing a particular age group to development of a vaginal diphtheria. Thank you.
Thank you very much, Dr. Sama. I think at this point, I would like to turn it over to Mr. Biodun. But before I do, please let's ensure that we consult the Q&A chat box. A lot of the questions have been answered directly, especially all the immunization questions. There are a lot of questions around sharing of the presentations. This will be done. We'll have the database of all the participants following the registration, and we'll share all the slides. And also, there are a lot of requests on the CITREP. This would be updated on our website. So let's ensure that we consult the NCDC website for an updated CITREP. So on this note, I'd like to say thank you to all our participants. Thank you to all our partners, and thank you to all our speakers for your time. Over to you, Mr. Biodun.
Thank you very much, Dr. Ladun, the head of the Department of Pediatric Surveillance, NCDC. I just feel in the interest of time, I saw about seven hands up trying to ask questions, I guess. I don't know whether we have time for that again, Dr. Ladun, or we just move to closing remarks shortly. I don't know, are we able to?
Oh, okay.
Let's take a few. Let me run through, if that's possible, run through some of the outstanding questions very quickly. The essence of this webinar is also to make sure that people leave with the right information and knowledge. I think it's important that we get Emma to come back and address the questions on antibiotic sensitivity. That's important for all of the ID experts and for case management. For the colleagues in Oyo State who are asking about who was trained, please direct your questions after this meeting to Dr. Bola Lawal, and you'll get your answer. There's the question about catch-up vaccination. I think Dr. Adejoke had answered that by saying that the catch-up vaccination for children under 4 or 4 and below can be done with pentavalent vaccine. And in the context of reacting to an outbreak, then TD is used for children that are above that age. I'm sure that after a review of stocks and all of the related logistical issues, NPHCDA will be coming back with sort of a bit more information about that. As there's a question about vaccination status of confirmed cases, most confirmed cases are either not vaccinated or under-vaccinated. I think that number is probably almost 90% as we speak. And when we refer to 0 dose, we refer to people who have not received any vaccine at all. They've not even received 1 dose. I don't know, question about absconding and all of that, I think that will be answered later. There are lots of questions about negative culture results. There's no one reason for the negative culture results. We believe they are multifactorial. There are issues around specimen collection, especially in the early days of the outbreak, issues about the storage media, about the appropriate media used even to try and culture and all of the rest. And we hope that we can answer some questions about those when we apply PCR techniques to some of the samples that have been sent to us in the NRL already. TD vaccine is already available for healthcare workers, clinicians, and others, as covered by the Dr. Adejoke's presentation on behalf of the NPHCDA. So please liaise in your respective states with the NPHCDA or state PHCDA to make that possible. I mean, I'm aware that we are using stocks that were meant for antenatal clinics, but the indication for use is very well justified. There's a question about shortages of diphtheria-containing vaccine. There is no shortage of diphtheria-containing vaccines in the country. Pentavalent vaccines are available. I think the challenge is with TD vaccine, which you require for people above 4 in the quantities that are required for reactive immunization, basically. So I think that is all as far as the questions to be answered are concerned. We thank you all for your time and for your interest. Please, if you have any outstanding questions, you can always do an email to the NCDC and we will try and provide the answer to you directly. Back to you, Biodun.
All right, thank you very much, DG. I think we've really been able to done a lot of justice to the questions asked. So it's just to appeal to colleagues raising hands. It's past the hour of 12, and we don't want to
get Emme to answer the questions on antibiotic sensitivity?
Very well, sir. Very well. So, Ms. Emme, if you're on the call, I believe you have, please, a quick one. Response.
Okay, yes.
Yeah.
Okay, thank you very much. So the antibiotics, we submitted the isolates to 6 antibiotics based on the UCAST guideline. So, and we used the disc diffusion method for the testing. And out of the 6 antibiotics, only 2 were sensitive to, that is erythromycin and tetracycline. Yes, plans are ongoing to also do some confirmatory tests, like further tests like the MICs, and also to do resistance mechanisms on them. But for now, what we have is a disc diffusion method. Over.
Okay. So thank you very much, Emme. I believe if there are other clarifications being sought, just as DG mentioned, we can reach out to any of the NCDC colleagues we know, and they will get across to Dr. Lawa, the IMTWG, collate the questions and get feedback across to us. All right, thank you very much, distinguished colleagues. I think it's just to yield the floor now to the DG. There are a couple of issues to follow up here, although there's a question around the age range for, maybe based on the experience so far, for females that are at risk of vaginal cutaneous diphtheria. I'm not sure whether we have enough data yet on that, but I believe we can explore that conversation further. And the issue around booster doses, I'm sure these are an ongoing conversation. As we have additional information in our subsequent webinar, we will be able to do that. So the email has been posted on the chat box. If you need to have especially our colleagues that have their hands up. We're very sorry we couldn't take that now. So you just send your questions or concerns to bola.lawal@ncdc.gov.ng or comms@ncdc.gov.ng. It's on the webinar chat, so you can just avail yourself the opportunity, please, so that we can manage our time as expected. Okay, so that'll be fine for now. It's left to yield the floor to the DG for the closing remarks. Director General, please.
Well, what can I say? I think I've been thoroughly enlightened. Even, I mean, people might assume I'm an ID subject matter expert, but I have been thoroughly enlightened by the faculty today, lab, clinical management, NPHCDA, and I remain exceedingly grateful to them all for their contributions. Thank you to all the partners who have made this possible, both in terms of the webinar and, of course, the outbreak response in the various states. MSF, WHO, the state ministries of health, and other partners. Thank you all very much. Thank you to gentlemen of the press who joined this event. Our comms team will be on hand to take any follow-up questions that you may have. I thank the NCDC team, the technical working group, our various partners, Nigerian Society for Paediatric Infectious Diseases, the Nigerian Infectious Disease Society. Who else? This is the problem when you start mentioning names, that you leave out a few people, and all others who have contributed to this and the first in the series of these webinars. The Nigerian Medical Association, Paediatric Association of Nigeria, how can I forget my constituency? And the Association of Public Health Physicians of Nigeria. Thank you all for your partnership. I mean, the NCDC, people think we're like a big standing army we can deploy anywhere, but we actually are a small team, and we are only able to do what we do because of the partnership with people in the front line in the respective states, all of our other partners in country, eHealth Africa, who's given us a safe platform to use today. People remember the challenges that we had with the first webinar. I mean, I'm still blushing from some part of what happened there. Of course, it would be, I cannot but mention UKHSA. We started off the diphtheria project as preparedness. We weren't thinking about an outbreak. It's just, look, there's a challenge. We know immunization coverage is poor. Cases may arise. And that was really, really, really timely because it put us in a better place to respond to this outbreak than we would have been if we had not started any of the laboratory preparatory actions. I'm particularly grateful to WHO. This is the first outbreak for which there will be diphtheria antitoxin in the country. We pushed, and I think within the first 10 days or so, we had DAT in the country. And this, I'm talking about DAT in particular because it's important that colleagues on the front line in clinical settings, you report suspected cases once you get them. If cases are not reported according to reporting channels and get to us, then we cannot prepare a response. So if we had learned earlier of the first few cases, then we would have prepositioned diphtheria antitoxin earlier, and maybe we would have saved a bit more lives. And the same happens with any other outbreak that you may have. If you look at the history of this outbreak, you will see that morbidity and mortality changed dramatically from when diphtheria antitoxin became available. And of course, the lesson from this going forward is we will always keep some stock of diphtheria antitoxin on hand as part of the national stockpile. So thank you all very much. It's been a very interesting day, which is why we've gone over time, but like every good thing, this must come to an end. So thank you all very much for your time. Bye for now.
Thank you very much, everyone, and see us at subsequent meetings. Over for now. Have a very productive week ahead. Bye.
Thank you and bye.